The goal is to try to present a translational talk, and I think in a sense, this is a topic that merges interests for people from the basic sciences who deal with hypertrophy, vascular disease and infarct, genetic abnormalities, inflammation, etc., many of which then contribute to the pathological or pathophysiological process of heart failure that ultimately affects patients in detrimental ways, whether sudden death, which will be the focus here, or death from pump failure. So that's in a sense a segue for the clinical problem that we're ultimately addressing is sudden death, and with really a focus for patients in heart failure. Because sudden death is such a large magnitude clinical problem, VT, ventricular tachycardia, and ventricular fibrillation are often the most frequent mechanisms, though not always, but the most frequent. And here's an example of actually from a Holter monitor of a patient who basically had sudden death at the time of the Holter sinus rhythm, a PVC sinus, and then monomorphic ventricular tachycardia that then degenerated to ventricular fibrillation. And I think as Dr. Albert had alluded to in her first talk, I mean, this is a challenging problem because this occurs in an unpredictable manner. It's very tough to identify the groups at risk, and it's really tough to understand the processes involved. What we're going to do to kind of approach this is to really talk on a number of issues in the brief time I have. Just some very brief mention of the studies of what's known about arrhythmia mechanism with the focus on things that have been from my lab. The issue of time of day dependence of VT and VF that she alluded to, a canine model of non-ischemic heart failure that we're using to really sort some of these issues out, the circadian influences on VT, a little bit on biochemical alterations, and some getting into an area that is a new area for us, but some of the mathematical area of nonlinear dynamics, and then summary and conclusion. And so let me introduce this by saying, as Dr. Eidecker really pointed out, that arrhythmias occur by usually one of two mechanisms, either reentry with some block somewhere, slow activation around that block, and reactivation. But it can also occur by non-reentry mechanisms, whether delayed after depolarizations or early after depolarizations. And this is one of several slides that kind of schematically summarizes several years of work, but it really shows that for studies that we and others have done in mapping with plunge electrodes in the human heart, as well as in the infarcted canine heart, as well as in a rabbit model of heart failure with pressure and volume overload, that one can demonstrate evidence of reentry occurring as a mechanism for which VT initiates. But in addition, and I would say that our group was one of the first to really go and point out the presence of and the importance of non-reentry mechanisms in the intact heart as two real mechanisms that ultimately can lead to ventricular tachycardia. And again, the slide that summarizes several years of work. This is a schematic that reflects collaborative work between Don Burz's lab and mine, showing that in the setting of non-ischemic heart failure, and now going from whole heart mapping to cellular studies and looking at intracellular calcium and measurement of ion channels, the bottom line is that we've at least tried to propose some of the key biochemical alterations for why heart failure is arrhythmogenic. One is that the sodium-calcium exchanger, which is upregulated, one depletes the SR of calcium and leads to some of the contractile dysfunction, but also basically mediates the transient inward current, and it, along with the changes in repolarization currents, provide an arrhythmogenic substrate that is then enhanced by preserved beta-adrenergic responsiveness that basically leads to calcium release and ultimately DADs and potentially even EADs. And then to complement that, this is a schematic from work that Shwin Ai had done when she was in the lab prior to her joining the faculty at Rush, but some very nice work showing that in heart failure, and this is true both in human as well as in animal models of heart failure, The problem is not just only in ion channels, but also in connexins, that these are schematics of gap junction and connexons, that there is a decrease in total amount of connexins in heart failure, and that's not just a problem with the amount of connexins, but also the phosphorylation state, and also changes in phosphatases that contribute, so that, in a sense, kind of pointing to some of the complex pathophysiology underlying the arrhythmogenic substrate. And so we've studied this in detail, both from a whole heart mapping approach and from a cellular biochemical approach. But as a clinician and someone who deals with the clinical side, one is struck with the fact, as again what Dr. Albert alluded to, is that for sudden death just doesn't happen any time. It can happen throughout the day. But here's showing several studies that say that look at patients post-MI, that there is an increase in incidence of sudden death in the early morning hours, usually between 8 a.m. and noon, and that's true for total sudden deaths. It's true for the occurrence of MIs. It's true for occurrence of PVCs in a vulnerable population. It's true for sustained ventricular tachycardia in patients post-infarct. And it's also true for VT in patients who have defibrillators, and just looking at when their episodes occur. So the issue is, how do you study this? This is a challenge to study in a patient population with this as an infrequent event, and you're trying to at least understand the substrate for what's involved over here. And what we've done is to, if you will, propose a hypothesis to say, okay, if there's a time of day variation in terms of arrhythmia prevalence, then it may involve time of day variation in a number of factors. So now we're talking mainly about the heart failure substrate. We're talking about potential circadian influences on these, but it also involves potential changes in gene expression that may vary throughout the day, whether in ion channels or phosphorylation state. It may involve changes in sympathetic and parasympathetic interactions and innervation, as well as beta responsiveness. And then for patients, this is often in the setting of medication, perhaps electrolyte abnormalities, that in addition to sympathetic, parasympathetic influences, or variability and repolarization that's been pointed out, as well as, in this case, effects of ectopic beats and how that suddenly changes the substrate. So to really go and do this, we needed to kind of develop a model that allowed us to study in more detail and really address this need for a large animal model that perhaps would show some time of day dependence, at least in arrhythmias, in which to gain a handle. We had extensive work with a pressure volume overload model in the rabbit heart, but we then moved that to the canine heart for several reasons. One is that, as well as the rabbit, that dog is more similar to man. One can induce disease models in that, but then also there's greater heart size and allow for sampling for biochemical studies. And also for ease with monitoring and such. And basically, with this model of combined pressure and volume overload over the course of several months, we get cells where the hearts have hypertrophy with higher heart rate, body weight. The cells are longer, they contract less well. When we do Holter monitoring, we see spontaneous arrhythmias or sinus and PVCs and a run of spontaneous non-sustained ventricular tachycardia. When we give norepinephrine, we can enhance those arrhythmias, and we can enhance them more easily in this failing model than in controls. When we do three-dimensional mapping to look at the underlying mechanism, we can see that this, the VT primarily initiates by a focal non-reentrant mechanism. That's shown here's a sinus beat, the first couple beats of VT, and the point here is that there's latest activation of the sinus beat at point A, and then over here, and then after several hundred milliseconds, there's no activation, and then the first beat of VT occurs at a distant site here in the apex here, and this just shows activation proceeds pretty rapidly. So the mechanism is similar to what we see in human heart failure. Here's some conduction abnormalities. This is work done by Jan my lab looking at, showing slowing conductions and associated with decrease in connexins and change in connexin phosphorylation. So the model really allows us to see, if you will, what we see in humans with an arrhythmogenic substrate, but to our joyous surprise, if you will, we were able to see that there was a time of day dependence in this, that here's recordings from 0 to 6 a.m., occasional PVCs, and now we see runs of ventricular tachycardia occurring in the early morning hours, and then later in the day less. And if we look at either number of PVC episodes, the duration of VT beats, or PVCs, we see this time of day dependence that we see in humans. So this is a good start for trying to look at the phenomena. I'll just basically talk about some of the biochemical work that's kind of in process. By having a model where we have time of day dependence, we can look at things like, in this case, beta-adrenergic responsiveness. So comparing kind of early morning to late morning responsiveness to, in this case, isoproterenol infusion, we can see that in controls you don't get much difference in the time of day, but in heart failure, these are control dogs, in heart failure dogs, when you give isoproterenol, you get a greater response in beta stimulation with the sinus node, an increase in heart rate, but you actually get less enhancement of contractility, and you get a disparate effect on QT, where actually the QT fails to shorten. So you have prolongation, relative prolongation of the QT interval, showing that even in these two time periods, that a heterogeneous response in the setting of heart failure gives you now some contribution to the arrhythmogenic substrate. And then we now have, we've done some studies now looking at biopsy samples obtained at various times of the day, where we now begin to look at gene expression and how that changes over the course of the day. These are tough studies to do, and we've already got some preliminary data showing that some metabolic genes have time of day dependence, but these are ongoing studies here. But we were interested in complementing this with an assessment of the electrophysiologic substrate. So we started with a more well-established set of parameters, if you will, which is heart rate variability. And it's known that the heart rate does vary from beat to beat. It's known that in disease states that changes and the heart variability decreases. And we're looking at this not as an endpoint in itself, because I think ultimately this kind of parameters, while useful, have kind of a mild predictive effect. And what we're really trying to look at is the electrophysiologic state on a dynamic basis. But for us, it's a place to start. And people have looked at various parameters to look at the degree of variability. But then also we're doing Fourier analysis on the waveforms, as people have looked at high frequency and low frequency components as a reflection of parasympathetic and combined sympathetic parasympathetic balance. And again, as a starting point, we use that because people have shown that a decrease in the low frequency component is associated with increased mortality. So here's at least a parameter that in patients is a poor prognostic indicator. Is that changed in our heart failure animals? And so what we have here is work that Yujie Zhu had nicely done in the lab. We're looking at now Holter recordings from dogs, and in blue is baseline. And then in the pink is after 240 days, and then the red is after 720 days of heart failure. Looking at the time of day changes from going from midnight to midnight on a 3 hour by 3 hour basis for some of these various parameters. So looking at the ratio of the low frequency to the high frequency component, what's interesting is that as heart failure gets more advanced, that there's a shift in this overall curve. So this overall parameter reflecting kind of, if you will, sympathetic balance, if you will, decreases. But what's interesting is in the time from midnight to kind of 8 a.m. when there's this peak incidence of arrhythmias, there's a pretty significant shift in the control state, but this really goes away, and that the heart really starts off, if you will, if you consider this a more arrhythmogenic indicator, starts off more arrhythmogenic and fails to change there, so that over the course from the progression of heart failure, there's really very little change with that. Now, in a sense, we can only go so far with heart rate variability per se. It's helpful. It's a very indirect reflection of sympathetic parasympathetic balance. But it's, if you will, a segue into some other possible analysis of this really valuable ECG waveform. So at this point, this is mathematics for non-mathematicians presented by a non-mathematician. So you'll have to bear with me as to the details here, but I want to make a few points about how mathematical approaches can really help you with defining something as complicated as the electrophysiologic substrates. And that is that for linear systems that respond in a response is proportional to stimulus, that's pretty easy to understand. It's well behaved, it's understandable. But for nonlinear systems, small changes can have striking effects and unanticipated effects, as we know about the butterfly effects. Small changes could potentially have big changes down the road. And that there may be interactions between nonlinear systems, such as pacemaker cells and ectopic foci. And that in nonlinear systems, there could be abrupt transition or bifurcations that can lead to phenomena such as alternans. And that's been well described in the electrophysiologic literature. So as we move into something like chaos theory, chaos really refers to what seems like random variability, but really isn't. There's more organization to this, to the point where while we think of VF and AF as more chaotic rhythms, actually the variation of heart rate and sinus rhythm itself is quite chaotic. And the problem is as heart failure involved, the heart becomes less chaotic. And so is that something that can help us with the electrophysiologic substrate? Perhaps. So one other thing in terms of introduction, so we're aware of fractals. These are geometric structures that are composed of subunits that resemble the larger scale structures. For instance, the branching of a tree, you look at it from far away, you see the branching. As you go closer, you see that same branching. As you go to twigs, you see that same branching. The same thing in the Purkinje system, that there is a fractal-like structure in the, if you will, the anatomy of the heart, but it also applies to the concept of the heart rhythm, as I'll show next. And so the issue is that these are ways to assess that physiologic systems such as heart failure become less complex and less chaotic, and ultimately less adaptable and less able to cope with a changing environment. And so I show that here. So here's kind of a schematic, if you will, maybe the Purkinje system. You look at this area. Here's now the same pattern. You look at this area in detail, same pattern. So here's heart rate variability, and over the course of a couple hours, here's this variability pattern, but you pick a smaller area here, and you still see the same pattern. You pick now maybe a minute or two, and you still see the same pattern. So here is kind of the heart rate variability, if you will, over time for someone in a control state compared to someone with significant degree of heart failure. And what we see is that there is really very little variability in terms of the heart rate, in terms of cycle length, and that this fractal pattern, if you will, is less evident. And you can do a Poincaré plot where you plot one beat versus the preceding beat and looking at even the differences in cycle length between them. And in heart failure, this is much more restrictive. Now, how does that help you? Well, you can quantitate this, and so here's an example of a nonlinear parameter detrended fluctuation analysis where you're really trying to quantitate the fractal-like properties of the heart rate. So what you do is you look at the R interval as a time scale, and you both integrate it, but you detrend it, meaning that this is kind of trending upward. You take that away. You say, okay, I'm going to eliminate the trending part, and this is now, if you will, the detrended fluctuation analysis. And I'm going to take small segments and kind of plot them out over time, and I'm going to look at the slope just as a quantitative way of saying how this changes. And just to say that the DFA changes significantly and is more predictive of patients with VF or sudden cardiac death. And I'm going to wrap this up now, since this is for sake of time, to make the point that we do see that for some of these parameters that there is a real failure to adapt, that this starts off low and gets even lower during the critical periods of a rhythmic genesis, and the same is true for other parameters, in this case correlation dimension. And I'm going to just end on this slide here, which is to say, what are the clinical implications of future directions? And I think the point is that one can start to use mathematical approaches to look at something as complex as arrhythmia development. We're really using it to study circadian patterns, but in a more precise manner. Heart rate variability indicators are nice, and they have some predictive value, but moving to these dynamics, nonlinear dynamics, is important. And then once you do that, you can start to add on the other parts of the equation, QT variability, some physiologic versus non-physiologic QT changes, post-PVC changes in heart rate, post-PVC dynamics, and really work that's ongoing in collaboration with Ian Knowles in mathematics, and that my son Michael will actually be working on in the lab, is doing a differential equation-based modeling of the rhythm based on these things to ultimately go and try to do a better job of predicting arrhythmias. And I think as we move to a short period, more beat-by-beat analysis of how these change, I think that we can at least start to get to what has changed dynamically in a patient so that we can predict it with sufficient ways to then think about how we either want to change the clock as a therapeutic target, we want to do any pacing or other parameters to go and decrease sudden death. And I'll just end with the acknowledgement slide. UJ did the nonlinear dynamics work. Michael's going to be working on the differential equation-based approach. People in my lab who have done the mapping, the connection work from Jaja, and then collaborators at UAB, collaborators at other institutions as well, including Schwinn, who's here today. Thank you very much.
Thank you, Dr. Pogwizd. This talk is open for questions. Let me just start out. But so in your dog model, where you also have an increased susceptibility for events in the morning, does this happen right after the dog wakes up, or is this still while they are asleep? I mean, is there any correlation with the activity? Or also, have you actually tried to disturb the circadian rhythm to then see if this pattern goes away?
So the answer is, it's not immediately upon awakening, but that's also what the human data reflects. That's really in these early morning hours. It's a little tougher with activity assessment, given that it isn't as extensive and variable as what it is in humans, but at the same time, that's a potential advantage for having an animal model where you have this, because one is you actually can track the activity, see what the contribution is, and you can do what you're proposing, which is to go and do things like if you change the light-dark cycle, if you do other kind of interventions, what is the effect? And I think these are ways in which, while studies in humans are really important, and we are doing more and more of that doing this in a model allows that kind of, asking the kind of questions that would be really hard to do in humans.